Okay, good morning. Thank you for joining us. We have a very exciting session lined up, the future of PCI and beyond. We are excited to have a great set of panelists and my co-moderator, Tim Henry. My name is Bill Fearon. I'm from Stanford University. And so without further ado, we'll go ahead and get started with our first talk. Should we stent intermediate lesions to prevent future events? And Salman and Allana is going to be giving that talk. Thank you.
Good morning, everyone. Thank you so much, CVI, for having me talk about something that has been really exciting in the field of interventional cardiology over the past few years. A slightly change of topic. I thought I would change it to, should we stent vulnerable plaques to prevent future events? And these are my disclosures. So we know that this is the data from the Srihari registry, which included 12,000 patients. And what we found out that the patients who had IFR or FFR negative lesions still continued to have high event rate. You can see that at 4 years, the MACE rate in those patients with non-flow limiting lesions was almost 26 to 27%. So why are these patients continue to have events despite non-flow limiting lesions? Well, the answer lies probably in the presence of vulnerable plaques. These plaques are atherosclerotic lesions that in proper milieu can progress to coronary thrombosis, leading to acute coronary syndrome and MACE. And the characteristic lesion for the vulnerable plaques is thin cap fiber atheroma, which is TICFA, which is made up of this necrotic core filled with cholesterol and cholesterol esters, and then capped with a thin fibrous cap, which is about 65 micrometers. And in the presence of inflammatory situation, this thin fibrous cap can get infiltrated by matrix metalloproteinases and the macrophages, and subsequently led to degradation of this thin fibrous cap, leading to acute coronary thrombus. There are multiple ways to detect vulnerable plaque, non-invasive ways. I'll mainly talk about the invasive modalities. There are four FDA-approved invasive modalities that are shown to that can detect vulnerable plaque. The grayscale IVUS, which most of us are very familiar with. The radiofrequency IVUS, which is a virtual histology IVUS that can color code the plaque composition and subsequently can give us an idea as to what kind of plaque that is. The OCT has the highest resolution to detect thin cap fiber atheromas, and the near-infrared spectroscopy, which is the best technology in detecting the lipid content of the plaque and demonstrates the plaque in a chemogram as shown here, with yellow being the lipid plaque and the non-yellow segments are non-lipid plaques. So before we talk about stenting vulnerable plaques, it's very important to understand the natural history of vulnerable plaques. This was first demonstrated in the PROSPECT study, in which patients who had acute coronary syndrome and the acute culprit lesions were treated, and then subsequently they underwent coronary angiography and virtual histology IVUS, and a proximal 6 to 8 centimeter of each coronary artery was imaged. These patients were followed up for 3 to 5 years, and you can see that despite having non-flow limiting lesions, these lesions were angiographically mild, about on QCA of 32.4% stenotic. However, these patients continue to have high event rates at 20.4% at 3 years. Interestingly, half of those lesions were non-culprit related lesions. Half of those were in-stent restenosis, but the other half was non-culprit related events which were angiographically mild at the time of presentation. There were some indeterminate events, mainly cardiac arrest patients that were included. And on multivariable analysis, the predictors of events at lesion levels were plaque burden more than 70%, thin cap fiber atheroma, and MLA of less than 4 millimeters square. Further analysis shows that if the patients had all three characteristics, the event rate was very high at about 18.2% at 3.4 years. However, if they didn't have any of these plaque characteristics, the event rate was very low at 0.3%. In fact, if the plaque burden was less than 40%, those patients had no events over this course. Then the PROSPECT 2, very similar design study. The only difference was instead of the radiofrequency IVUS, they used intravascular ultrasound with near-infrared spectroscopy. Again, very similar results. Most of these lesions were non-culprit related events that happened at 4 years. The lipid-rich plaque study that included 1,271 patients used NERS IVUS, and that showed that the maximum lipid core burden index, if that was more than 400, that is, if the plaques contained more than 40% lipid, these patients had higher events, both at the patient level and also at the individual lesion level, and significantly higher rates. So does stenting really prevent these events? Well, theoretically, stenting causes new intimal formation and increases the fibrous cap thickness, and that can stabilize the plaque. And that was studied in the Prospect Absorb randomized controlled trial, in which patients with vulnerable plaque were randomized to absorb BVS implantation versus guideline-directed medical therapy alone and followed for 25 months. This study showed that at 25 months, the MLA in the patients who had BVS implanted was significantly higher than the guideline-directed medical therapy, which is no surprise because these patients got stented. However, most importantly, the patient who had absorbed BVS implanted, their fibrous cap thickness increased by 210 micrometers, a significant increase in the fibrous cap. Although this trial was not designed, was not powered for to detect MACE events, there was no significant difference in the target lesion failure or lesion-related MACE events between the two groups, and overall, it did suggest that stenting of these vulnerable plaques was at least not associated with any harm. And then on the basis of that, the PREVENT trial came in which the coronary stenosis of greater than 50% with negative FFR and meeting two of the following criteria for vulnerable plaques were included. MLA of less than 4, plaque burden greater than 70, TICFA, lipid-rich plaque, and they were randomized to preventative PCI versus optimal medical therapy. And we know the results, that there was significant reduction in target vessel failure at 7 years by 3 percentage points at 7 years. And death from any cause, MI, or repeat revascularization was significantly reduced at 7 years. So I've given you enough argument to stent these plaques. However, there are always two sides of a coin. There are arguments against stenting vulnerable plaques. Most vulnerable plaques, as we have seen, do not cause ACS. It has to be in vulnerable patients. And what are those vulnerable characteristics of the patients? Insulin-dependent diabetes mellitus in the Prospect study was one of those. Are there any other characteristics? Are there any characteristics at the molecular level? Expression of matrix metalloproteinases, low endothelial shear stress, those have to be identified. Also, vulnerable plaques are dynamic. In this study, patients who were on 20 milligram of atorvastatin versus 5 milligram of atorvastatin had significant increase in the fibrous cap thickness over a period of 12 months. Moreover, the lipid arc decreased and macrophage grade also decreased. Results from the Pacman AMI trial, all patients were on statin after MI, and they were randomized to alirocumab, which is a PCSK9 inhibitor, versus a placebo. And that showed that the alirocumab decreased percent atheromatous volume by about 2.1% versus 0.9%. Also, there was a decrease in lipid plaque content by about 41% and increase in fibrous cap thickness by 30 micrometer. We have to look at the baseline LDL levels in the PREVENT trial, 88 and 93, and at follow-up was about 64. There is an argument for more aggressive lipid control in these patients. The use of DAPT was higher in the PREVENT trial, which may or may not have affected the results. And of course, the MACE rates have declined, as we have seen, from the Prospect 1 study to the Prospect 2 study. And of course, we have to look at the exclusion criteria of the PREVENT trial. Lesions less than 50% were excluded, more complex lesions were excluded, instant restenosis, bypass graft interventions, bifurcation stents requiring two stent processes, heavily calcified or angulated lesions. Does preventative stenting in those lesions fare well? We don't know. So overall, MACE is still common with IFR, FFR deferral. Vulnerable plaques are common and predisposed to higher MACE. Vulnerable plaques are associated with high plaque burden, lipid content, and TICFA, and MLA of less than 4 millimeters square. PCI vulnerable plaques has been shown to reduce MACE. Aggressive lipid-lowering therapy has been shown to stabilize the vulnerable plaque. It's a dynamic process. There are more studies that are coming out, like Interclima trial, that will shed more light on the management options of these patients. Thank you. Happy to answer any questions.
Great, very nice talk, Salman, thank you. Want to encourage the audience to participate, so if you have a question or a comment, please just raise your hand. While we're waiting for that, maybe we can just ask the panel a little bit about their approach and their interpretation, I should say, of the PREVENT trial. You know, are we ready for prime time? Should we be stenting these lesions? And in particular, you know, I think translating the findings may be challenging. The ability to identify vulnerable plaque for the average interventional cardiologist, I think, is a challenge, because it's a challenge for the core labs to even identify it. They disagree. So anyway, maybe we can start at the end of the panel.
Yeah, so this is fascinating. This is one of my favorite evolving areas of cardiology right now. It's very interesting. So I think one question to ask is, you know, in any given case, what's good enough for your patient that you have on the table? So how complete an evaluation do you have to do, and then how do you respond to the data that you obtain? So if we look at FFR, pressure wire-based measurements, for instance, there is some general correlation between the most flow-limiting plaques are often those that do have a lot of these features associated with the lesions, but clearly we miss other spots. So are you going to go and then do OCT of every single vessel, and ultimately is that going to be better than, you know, working aggressively on optimal medical and lifestyle therapy? And my other big thing that comes up in my mind about this is that not all stenting is equal. So if you look at trial data, for instance, versus everyday practice, how many people are excellent coronary imagers? How many people make sure their stents are all well expanded, there's no edge dissections, all these kinds of things? So if you do a bad job on stenting, I think by far the patient is worse off than if you leave some of these vulnerable plaques alone and treat them with excellent medical interventions. So I think there's so many unanswered questions. I don't think we're ready for prime time to tell everyone to slap stents in all of these lesions.
I agree. I think this is fascinating technology and a movement towards something that could be pretty beneficial for our patient population. We've seen these cases all the time. You know, they come in with ACS, we see the culprit lesion, we stent it, their other lesions look okay, and then 2 years later, they have another ACS event in an artery that we didn't expect them to. So if we could have that crystal ball and say, yes, if I can prevent a STEMI in that location, why wouldn't I? To Dr. Hall's point, the quality of PCI certainly has to be taken into consideration. Are we using image-guided PCI? You know, so we don't want to create another problem for a patient by treating one problem. But I think it's a fascinating area, and I'm really excited to see where this direction leads us.
So this is an interesting question. Currently, the guidelines don't support in stable patients. The current guidelines in the setting of the ischemia trial does not support intervention even in patients with a significant coronary disease. So it's hard to justify. I mean, the shortcomings of PCI and the way that the PCI is implemented, as it was mentioned before, it's also an issue. And to be honest with you, I don't know if I'm capable of identifying. I don't think I have the tools in the cath lab, and I'm not sure that I'm capable. You know, cranking cases, doing structural work, and cranking cases in the real life of the interventional cardiologist. I don't think we're capable of identifying those vulnerable plaques. And then, you know, if you stent, you got to make sure you stent well, and you do a good job. And I'm not sure that that's the issue. I think that we have to you know, emphasize the use of imaging, and then start fine-tuning. We can identify those vulnerable plaques in the average cath lab.
So just excellent talk, Salman, and just a few brief comments, because I think this is a really controversial area right now. And at CRT, we actually looked at the PREVENT trial, and there was a little session to predict whether it would be positive or negative. I think the most surprising thing about the PREVENT trial is not that it was positive, but the event rates in both groups were so incredibly low. And I think we have to remember that we've come a long way. And so in last session we talked about lipids. I think as interventionalists, it's incumbent on us to make sure people's LDLs are less than 55. Almost every patient we see fits in the high risk group. And so that's where it starts. We need to do that. In terms of PCI, I don't know the answer right now, but I think the insights from the multi-vessel STEMI trials tell us that, you know, the non-culprit, and we've shifted there, and we are fixing non-culprit lesions. So we're already doing that. Problem is guidelines and appropriate use things haven't kept up as well. But the last comment I'll make is, you know, we're in the Gentuity trial, so I've been doing a lot of OCT in combination with physiology, and I'm surprised at how often the OCT does not match the physiology. And I don't know what to do with that yet, And I think we need more really good trials.
Yes. To add to that point, there was a combined FFR trial too, in which 300 patients were included, and all of those lesions were FFR negative, and 75% of those patients had TICFA. So really, we really cannot identify those lesions. There have been studies that have shown that as the lesion severity increases, the likelihood that the FFR also increases, but again, the correlation is not that strong.
Once again, great presentation. I agree with my other panelists here. Show of hands, how many people have OCT in their labs? Okay, all right. So not every place has OCT, and like some other panelists have mentioned here, even high definition IVUS is not available in several labs across the US. And the interpretation of vulnerable plaque on just regular IVUS is kind of tricky for most people. And so I think it's really challenging to say for people to identify vulnerable plaque on a regular basis in the lab. So I agree that right now is not really prime time for us to move ahead. And then optimizing, like the studies have shown, optimizing lipid management is probably the way to go. If we can continue to work hard with our patients to get their LDL levels less than 55 using the tools that we have, I think we can improve patient outcomes.
Yeah, and I would add to that point, what about also looking at anti-inflammatory studies? Like, I mean, you have interleukin-1 inhibitors, we have colchicine, and maybe a combination of statin-reducing therapy and those inflammatory material, because you need a vulnerable patient as well. So if we reduce that inflammation, then maybe we can actually also reduce the rupture of those vulnerable plaques. And we have seen these vulnerable plaques evolve over time, and so these factors definitely could decrease the incidence of MACE. And we have seen the reduction in the MACE coming along, as Tim pointed out, and then from like 11% 10 years ago, and now down to less than 8%.
That's actually an excellent point. Sorry to interrupt for 1 second. I was just about to say the same thing, because I noticed this in my own group practice, actually, because I had to review the data on colchicine for a journal club, interestingly enough, and I was like, geez, this is pretty good data we have on this. And I think inflammation is very much under addressed in so many of our patients. After you've optimized their lipids, they have that residual inflammatory risk. And when I look at even just my local practice, I think I'm probably one of the only people that actually prescribes colchicine somewhat regularly, so that may be another way to address some of this issue.
Salman, a great presentation, but I think I agree with the panel. We don't have OCT, it's hard to identify it. It's a great area. I want my vulnerable plaque stented, yes, but the problem is when you fill the appropriate form at the end of the procedure, I don't see any of the options here. IFR negative, no stress test. So I think if something goes wrong down the line, I think it's going to be an issue. So I think there's an area of definitely more work, like yourself, great job in that space, but PCSK9 can help, meanwhile, till we have a better answer and implement in the guideline.
All right, thank you very much.
Thank
and
you.
We're going to move on now. And our next speaker is Jacqueline Tamis-Holland, who's going to talk to us about STEMI management, present and future. And she has really been a mainstay of in the guidelines and summarizing where we should be for STEMI management. So I'm looking forward to this.
Thanks, Tim, and thanks, Manos, and the whole planning committee for inviting me to be here. This has been an amazing conference. I was tasked with this talk, and I'm going to really, unfortunately, it's a magnitude of information to talk about. So I'm going to really try to focus on some little, just sort of a small focus on future management. So I think we've made great progress. This is going to be my only slide on kind of current care, because I'm going to be talking about the future. We've made great progress in the last 25 years in treating patients with STEMI. It began in the 1980s when DeWood and colleagues first recognized that on autopsy studies that thrombus was, acute MI was associated with thrombus, and this data led us to understand and implement treatments and pave the pathway for fibrinolytic therapy to treat STEMI patients. First studies was ISIS-2 and GIST showing in ISIS-2 close to a 50% reduction in cardiovascular mortality. That's huge with the combination of aspirin and fibrinolytic therapy. But then shortly thereafter, we had Cindy Grimes and colleagues and a whole slew of more information looking at primary PCI, showing that it's beneficial compared to fibrinolytic therapy. And then our focus became on treating patients with primary PCI and getting that artery opened. But it was really done not systematically until there were a lot of initiatives like the Door to Balloon Time Initiative, Get With the Guidelines, and Alice Jacobs, Tim Henry, and a whole group of people got together and created a concept of systems of care for STEMI, focusing on the importance of working together to improve door to balloon time and total time to get the artery opened. And now, I think what we're focusing on is we get the artery open, we care about, epicardial restoration of blood flow, but it's really on the tissue level restoration of blood flow. And I think the focus now, maybe for the last couple of years and hopefully in the future, will be really on improving tissue level reperfusion and reducing infarct size. And so what my focus on for today will be that. I mean, there's tons of information on medical therapies and further improving things, but I really want to talk about reducing infarct size. So there's two obvious: the general category, which is just get better reperfusion, get the patients there quicker, get the artery open quicker, and then, of course, reducing reperfusion injury. So can we tighten our reperfusion times? I mean, I think there's a lot of data. We would all agree that our door-to-balloon times, the majority of the country achieves that within 90 minutes, and most of our median door-to-balloon times are about 55 to 60 minutes, maybe even less than that. So we achieve that in a large majority of patients, but I think we really need to remember those transfer patients. Now, that's about 20% of the population of the United States with MIs. It's not a huge amount, but it's not a small amount. And in Canada, I'm looking at Vlad here. In Canada, it's probably even more than that. So we really need to focus on transfer times. And this is data from Jamie Jollis and colleagues looking at transfer times. Now, I know this is a very busy slide, but what I'm going to try to do is to try to, I don't know how to do this pointer thing, try to sort of point out, well, I'll just sort of tell you. Oh, here's the pointer. Okay. So these are box and whiskers plots. For those of you who are not familiar, the top part of the plot is 75th percentile. So 75% of the patients have achieved that. If you look here in this, just focus on the dark, sort of gray-blue boxes. The goal is 120 minutes. That's way down here. The majority in every quarter across the United States in participating hospitals did not even achieve 25% of their patients achieving a door-to-balloon time within 120 minutes. So we really do need to focus on newer ideas. Consideration of reintroducing the lytic again, giving lytic and then doing timely transfer and doing cath within 3 to 24 hours as the guidelines recommend. So, not saying I want lytics to come back, but if you're not going to achieve that 120 minutes, you really do need to consider that. In Cleveland Clinic, we have new ideas of rendezvousing. We have the hospitals, the EMS let us know ahead of time when they're coming to a non-PCI hospital, and we rendezvous with them in the helicopter pad so we can increase our transfer times. So I think we need to start thinking about innovative ways to decrease our time to reperfusion for transfer patients. What about missing infarcts? There's a lot of patients who we miss those infarcts. So yeah, we do great times on the patients who have those classic EKG changes, but what about patients who have subtle ST elevations? Those are the ones we miss. Those are the ones who have large myocardial infarcts and large infarct size. And there's data looking at AI to identify patients beyond the usual STEMI criteria. And this is just one of several studies looking at AI, and you can see here, this is the area under the curve for an AI model to identify an occluded infarct compared to usual STEMI criteria or EKG experts. Sensitivity was 80% and specificity was 94%. So I think we need to consider other models to identify that occluded artery and go beyond the typical STEMI criteria we use on EKG. So what about tackling reperfusion injury for the remaining time? And hopefully I'll get this done. I want to talk a little bit about reperfusion injury. Reperfusion injury, by definition, is the injury impaired when you open the artery. So yes, there's the ischemic injury before you open the artery, and there's reperfusion injury once the artery is opened. And that's a constellation of multiple factors. That includes edema of the myocardial cells distally, vasospasm, embolization, intramyocardial hemorrhage. It's a whole bunch of different things that causes reperfusion injury. And we really need to start focusing on reducing reperfusion injury to decrease infarct size. So there's been lots of methods that have been tried. Unfortunately, in the interest of time, I'm only going to mention a couple that are still under investigation. I'm happy to talk offline about the remaining. So supersaturated oxygen, I don't know how many of you in the audience use it, we can ask that at the panel later, but supersaturated oxygen, a very interesting and unique way of decreasing infarct size. It's associated with lower rates of microvascular obstruction and improved infarct size. So this is data that what it does is it takes blood out of the body, supersaturates it with aqueous oxygen, and then delivers it down the myocardium. And this is done for 1 hour after your PCI. Really great results in reducing infarct size. Some non-randomized data showing reduction in events compared to historical controls from the INFUSE AMI trial. So some really good data on that. But I think we still really need some more randomized data of larger trial sets. So it's FDA approved, people are using it, and I think we need more post-marketing approval of this to understand its role, but really great promising data. What about unloading the left ventricle? Well, we know that the data on animal models show a reduction in, theoretically, it reduces myocardial oxygen demand, it reduces LV size, and it's really promising. So Naveen Kapoor and colleagues are doing the door to unload trial. They're looking to randomize about 700 patients to a strategy of unloading the left ventricle with Impella CP, followed by 30 minutes of waiting. And the animal studies show that it's the 30 minutes of waiting that actually reduce the infarct size compared to usual care with primary PCI. And the primary endpoint will be infarct size at 3 to 5 days. So really exciting work, and we'll see if that improves our decreases our infarct size. Lots of other data, ischemic post-conditioning. You open the artery, then you have a series of 4 inflations for 30 seconds, followed by 30 seconds of relieving the inflation. And this is called ischemic post-conditioning. Dynami 3 IPOST did not show a difference in outcomes with this ischemic post-conditioning, but there are future studies looking at this. So, this is just sort of some of many studies, a great review article by Welt and colleagues on all of the future studies, lots of studies looking at IL-2 inhibitors, inhibitors of inflammation, PCSK9, and then mechanical ways of reducing reperfusion injury. So the future is really great. There's been a ton of studies that did not show a benefit, and I would argue that we need to identify the right patients. So my question is, does it make sense to assess IMR in the cath lab after your PCI? IMR is associated, an IMR of greater than 40 is associated with increased microvascular obstruction, and if we identify the right patient, should we target only those patients to decrease reperfusion injury? So the future is bright. We've come a long way in the last 25 years, and I think we have a lot more to look at, but I think the focus should be on reducing reperfusion injury. And I'm sorry I went over. Thanks.
Great talk and great summary of so much data in such a short time. I love the IMR call out at the end there. I think that it is important. A lot of the techniques that I think we've tested may have failed because we just weren't selecting the right patients. And if we could focus on the highest risk group, that could really help. I know you only had a limited amount of time, and so you couldn't cover everything. And so maybe during the discussion we can, well, if people have comments about...
The last talk is canceled, so you're free to have a discussion.
Okay, good. Well, one thing I wanted to ask you about, Jackie, is you didn't have time to talk about multivessel disease in the setting of STEMI, and that's a really somewhat controversial topic. And I think questions are, first of all, the timing of non-culprit lesion treatment. Should we do it at the time of this, initial PCI? Should we bring them back a few days later? Should we wait until they're an outpatient? So I'm interested in hearing your thoughts on that. And then also, certainly if it's an 80 or 90% lesion, fine. I think Complete showed us that we should go ahead and treat those. But what about the 50% lesion? I mean, should we be doing OCT? Should we be doing FFR or IFR? How do we assess those? And interested in hearing your thoughts.
Yeah, so that's great comments. And yes, there's too much to talk about, so I'm sorry I left all of that out. But I think the timing, there was BioVasc and Fire, was it Fire? I'm blanking on the name of the other study, but they looked at timing. And I think that the timing is, I think that we know it can work in stage PCI, and there's some data that suggests timing is to do it at the time of primary PCI might be better in terms of a reduction in MACE. My problem with those studies is that some of the control arm waited 17 days before the PCI was done. It wasn't done early on in the hospital. And the other problem with those studies is that they looked at softer endpoints and included peri-procedural MI as an endpoint. So I think we're not sure about the time, but technically, at least we know it's safe and maybe even potentially better to do it at the time of PCI. I personally do it as a stage procedure. Curious to know what other people do.
All right, overall, like outstanding, and so many things to talk about this, but you know, what I think the most important slide was your first slide of the data from the American Heart Association Get With The Guidelines in JAMA. We're not doing a good job. We've slipped. And STEMI, primary PCI for STEMI, has made more difference than almost anything else in interventional cardiology. Yet we're not paying attention in many parts of the United States. And I think a really important point, all of you out there know what your own site is. Make sure that your STEMI system's working well. Keep track of keep it up to date and do it. And I think that's the big thing. And then the second comment is, I really think this issue about microvascular obstruction is super important. I think the trials are negative because half of the people in the trials are going to be normal. So now if we can actually you can identify MVO right away. IMR is one way. There's multiple other areas coming. If anyone's interested in this, we're going to be starting a trial with a thing called core flow, and we need good STEMI sites to do it. But identifying MVO on the table, so then use SSO for those patients, right? Anyway, I'll pass it this way. And
to Tim's points, again, the STEMI program is great. If you have a STEMI program, it's perfect, but you have to keep an eye on the data, because we noticed after COVID, we slipped a lot, and the problem was door to EKG. So we have to dice the data to find why we are going beyond 90 minutes for door to balloon time. It turned to be the ER. They lost the technician at the front door to do the EKG, and it's taking them 20 minutes. So that's 20 minutes gone by just not getting the EKG done, not identifying the STEMI. The second problem we identified, also you have to work with your abstractor, with the abstracted data. Everybody, the operator sometimes mislabel a case as a STEMI, but this wasn't a STEMI even to start with. So you have to adjudicate in your system with every case if it's STEMI or not, and this is the data should be abstracted to NCDR. Because some cases are labeled as N-STEMI and the patient has been laying in the ER for 3 hours. The true point came up 10,000. Oh, let's activate the STEMI pager. Look at the EKG, there's no ST elevation. So that's an urgent case more than a STEMI case. So this data also, part of it data collection, part of it is entry, part of it adjudication. It's just one system. As Tim said and as you mentioned, you have to keep an eye on this data.
Yeah, I agree with you completely, although I would actually say, unfortunately, sometimes the opposite. They come to the lab with an occluded artery. They had 0.8 millimeters of ST elevation, so they didn't meet the criteria, so they're being coded as a non-STEMI when they were truly a STEMI all along with clear reciprocal changes. And that's what I was saying about AI. But and then in answer, one other comment about the FFR and timing, the use of it. So I think that the COMPLETE II trial will be a really fantastic trial. It's a trial looking at FFR guided or physiologic guided versus angiographic guided on the non-culprit vessel. But importantly, they're doing OCT sub-study. And I think that will be very helpful because we'll be able to understand whether it was the presence of the OCT before the PCI showed vulnerable plaque. It was the intervention on that subgroup made a difference. So I think we'll have a much better understanding with COMPLETE II.
So one comment here. So I think that the holy grail of primary PCI is identifying the patients with microvascular and microvascular damage. And this has been, so many trials have been done, anti-inflammatory agents, antithrombotic therapies, anti-complement, and now everybody talks about that, but SSO2 is different. Then you have to give up the radial access. We fought so much for radial access in STEMI, and realize that there's a mortality benefit. So you have to identify. You have to understand, is that going to work? You have to stay another hour, I think, in the hospital, and then the data are kind of weak. The data are kind of weak just to have a massive implementation of that technology treat the patients. And then you have to identify the patients who are going to benefit. So it's very complicated to move beyond reperfusion. I think, you know, I finished my fellowship in 1999, and we still, you know, we were talking about beyond reperfusion, amazing review articles, and we're still talking about the same thing.
Excellent talk. I really like how you divided between early perfusion time versus decreasing perfusion injury. And I'd like to talk a little bit about the first part and visiting the concept of a STEMI system with bypassing the ED. I'd be interested to know how many facilities or how many of you out there use a bypass your ED for STEMIs. Okay, so there is data that does show that properly employed bypass EDs and STEMI systems can reduce door-to-balloon time, but that system has to be reviewed regularly and make sure that there's good closed-loop communication between EMS, the ED department, and obviously the cath lab. But what are your thoughts on that, and do you think that is something are we capped at that technology or that process, or do we need to relook at that and try to improve that a little bit more?
Yeah, I think that the ED bypass is particularly advantageous when you have staff that are off-site for off-hour times, and you're getting that notification in the field, so the staff have the time to get to the hospital, and then you get them straight to the cath lab. The problem is off hours, if you don't get that, or you have staff that are traveling far away, it can't be done. So when we looked at it in New York City, we definitely saw tremendous decreased first medical contact to device times, but it was mostly during the daytime hours. And off hours, unless the hospital had an in-house cath lab 24 hours a day, it was very hard to implement. But I think it definitely cuts down. I mean, we've seen tremendous reductions, and there's data showing tremendous reductions in door-to-balloon time and first medical contact to device with ED bypass.
Great, thank you very much, Jackie. Any final comments from the audience? Okay, thank you very much. All right, so we'll move on to DCB, present and future, and Michael Magali will give us this talk.
Well, thank you so much, and thanks to the organizers for allowing me to talk about one topic that is really of interest to mine. I feel like I'm back to the future, because what is future about DCB for us in the US has been the past since 2009 in Europe and the rest of the world. So for any non-US based operator, please bear with me, okay? My only conflict of interest is that I had interest in DCB since 2017. And there's been research, and we've done a lot of work trying to identify what our colleagues have been doing and how we can benefit from that. So for the difference between DES and DEB, the main difference is that the balloon has a very high concentration of drug. It's delivered one time, very fast release, and of course you don't leave anything behind. Beyond that, DCBs have a very positive effect on endothelial function, so it does not cause any vasomotor problems like DES, especially in the distal vessel. And a great point about DCB is that it can cause late lumen gain. This is somehow limited to vessels that are from 1 to 2 millimeters. This is 4 months after using DCB. After 2.5 millimeters, this does not happen. But it's a great point for us to consider for DCB use in small vessels.
Sorry, Mike, if you don't mind, if you come close to the center, because they
sure.
lose you. Sorry.
Sure. So again, on using DCBs, the center here? Okay. All right. So for using DCBs, it's very important to properly use it. And again, US, we do not have the experience in that. So the main point is that to do very adequate preparation of the lesion, you have to have less than 30% residual stenosis, no dissections beyond grade B, and of course you have to have very accurate sizing with IVIS and after using nitroglycerin. You put in the balloon, you inflate it for about 20 seconds, and about 60 seconds is appropriate. And then another important point is that it is not a non-compliant balloon. It is a compliant balloon. This is an example that I got courtesy of Dr. Rugg in Egypt. They had to lobby for some cases because we don't have here. And this is a DCB that was size 1:1, inflated beyond beyond nominal causes perforation covered with a stent graft. So it's a compliant balloon, so don't inflate beyond nominal. Now, quick talk about the use. The main reason it's here and the on-label use is ISR. And I'm very bullish in DCBs, but let me give you some controversial data on that. So this is a Dallas study. This is an individual patient-level meta-analysis of 10 randomized trials comparing DCBs and DES in ISR, mostly single-layer ISR. And if you see here at 3 years, actually DCBs did worse than DES. And the odds ratio of this was about 1.3%, 1.3. And when they limited the data to DES ISR, DCB even did even worse, and the hazard ratio is about 1.5. So what am I saying? No, I don't like DCB? No, of course I do. But the problem with these studies is they excluded the mechanism of ISR, identification, IVUS, and they excluded everything that is very important in ISR. But for single-layer ISR, it is not unreasonable that if you fix everything, identify etiology, that you use another DES because another DES actually fared better in studies. But where do DCBs come really into play? This is a study done in 2013 in Japan. And I think this is a very, very important study. It studies actually the impact of using DCB on 1 stent layer, 2 stent layer, and 3 stent layer ISR. And the most important point is that in 1 and 2 layers, the DCBs did fairly well, and the risk of TLR at 1 year was about 14%. However, if you have 3 layers or more, you got a TLR rate of 41%, basically a flip of a coin. So in totality, looking at this data, maybe if you have a single layer ISR, maybe after identifying etiology, you don't get everything right, maybe using another DS is not a bad idea. It actually fared better than DCB. But if you have 2 layers, please never place the 3rd layer because it's like cancer in the coronary arteries. And DCBs do really well when you have 2 layers. All right, now, I am really bullish on DCBs, but maybe ISR is not the best use of them. And I think DCBs have great potential for a lot of other things that we should be excited about. This is a very important study showing basically the attrition rate of DES, whenever placed DES, very late cardiovascular events related to stents. And if you see it year 2, 3, 4, 5, and it probably doesn't stop, there's an attrition rate of 2% a year of cardiovascular events related to the stent that we place. So can DCB help with that? Well, where does this happen? If you look at this graph and look at predictors of restenosis, if you look carefully, you find the most hazard ratios are for diabetes, smaller vessels, and longer stents. So basically, diabetic, small, diffuse disease. And this is where DCBs can really come to help. This is the data from Basket Small 2 trial. They used DCB versus DES in small vessels. At 3 years, it fared the same. And when they, when they divided this into the Zeiss stent versus DCB only, again, fared the same. The worst was DCB plus DES, which is the people that needed bailout. This is our meta-analysis from 5 randomized trials, drug-coated balloons, drug-loading stents, 5 randomized trials. Again, MACE, all-cause mortality, TLR, TVR, same at 1 year. However, MI and late lumen gain was much better with DCB. And based on the other trial, we anticipate that beyond even 3rd year, 4, 5, 6, you will find that drug-coated balloons will fare actually better than DES because you don't have that attrition rate of the stent. Again, there's another meta-analysis of using diabetic patients, and you see strikingly different results. Of course, these are not randomized trials, but this is a huge prospect of using it in diabetic small vessels. This is a more recent study. The blue line is diabetics using DCBs. The red line is diabetics using DES, and you see a huge difference in MACE as well. And again, for all the CT operators in the room, we're very excited about this. With CTOs, you have negative remodeling, distal small vessels that you don't know how to size a stent. And for using DCB in that technology is very, very promising. It's been used actually all over. And another important use of DCBs in CTOs is that when we try to do STAR, we try to do ADR, and we fail, and we do STAR and let the wire spontaneously go into the distal vessel. We have a long subintimal tract that we don't want to stent, so maybe using DCB in that setting can help maintain patency until the patient comes back. These are a few examples that I leveraged from Canada. This is courtesy of Dr. Bilal Iqbal in Canada. If you look here, you see that small distal PDA CTO, and this was treated with just antegrade wiring and drug-coated balloon. Very, very, very appropriate to use drug-coated balloon here. You don't want to stent a small distal diffuse vessel. Another example is this case. This is an LID CTO. And actually, this case was complicated by left main dissection. That was treated, and then the LID was crossed with STAR. And you see the dissections here. This is a case where DCB was used, and this is 9 months after, and it feels really well, and the dissections are healed. Another important use of DCP that I'm also really excited about is using it in side branches. And this is a complicated slide, but what it basically shows is that if you use, whether you use a DCB in the main vessel or side branch, consider whatever the main vessel side branch, you'll find that diameter stenosis and lumen gain at the side branch if you use DCB is much better. And this is our meta-analysis again. It shows that late lumen loss is much better with DCB. A lot of clinical studies are needed though, because these are very small studies. This is another example from Canada. You see this lesion no one wants to see. You don't want to compromise your LID, but you have to treat that diagonal for symptoms. This case was treated with cutting balloons and DCP, fared really well. And again, you maintain your LID, you don't cause any problems in the main branch. So basically, take home here, we have to be careful with the price in US. It is very expensive, and I don't think we still can use it in all the applications we need to use. Hopefully we're going to get this price down, and hopefully be able to use it in every indication we need to use it at. And be careful, it's a compliant balloon, and don't inflate beyond nominal. And using it in small vessels is probably going to be the best bang for our buck in using this technology. In ISR, mainly use it in 2 layers of stents. Do not add a 3rd layer. DCB fared really well with that. And again, the main bullish indications I have in DCB is the small distal vessels, osteum side branches, and CTOs. And if you have to do STAR, maybe add a DCB and make a superstar. And thank you.
Thank you, Michael. Great summary of the data and applications. I particularly liked, you're focusing or mentioning the issue with the fact that the DCB is just a delivery platform. And really, when we're faced with ISR, we need to do our best technique, intravascular imaging to identify what the issue is, lesion preparation with all the tools that we're used to using, intravascular imaging to make sure we've really prepped well. And then the last thing is just delivering the drug with the DCB. And some people even argue don't even need to take a shot after the DCB, because it's really just getting the drug in there. And I think that's a key take-home message as well. But one of the things that we're facing at our center is how to implement the technology. You also mentioned the cost, at least now until we get Medicare reimbursement, until other competitors come out there. And so I'd be interested in hearing how the panel is implementing this technology. Do they have algorithms? Are they only using it for certain types of ISR? Are they using it for other areas too? So Mauricio, do you have some comments on that?
Yeah, so it's been very difficult to implement. So we work in Cleveland Clinic. It's a large organization. So there's a directive from the leadership that we're using only in instant restenosis. The other issue is whether the company makes you buy it or you can have it in consignment. That makes a big difference. Each one of these balloons is $5,000. So and then you don't get paid. You just get paid for POBA for that. So I think the practicalities more than the science of the balloon is what's dictating the use.
Great. I think we had a question. Yeah, please go ahead.
Yeah, first of all, I would like to thank Michael and congratulate him for the work that he has done on the topic of drug-eluting balloons before they got approved in the States. And one brief comment, if we allow me the question. So the brief comment is that good preparation is key, and in my opinion, especially for ISR cases, you need something more than non-compliant balloons. You need a cutting balloon in order to have the drug being delivered. And my question is, if I'm not wrong, please correct me, in the States, only the paclitaxel-eluting balloons are available, right? For the rest of the world, do you feel that there should be a preference for sirolimus versus paclitaxel-eluting balloons, or vice versa? What's your opinion? Do you think that we have data, strong data, to support preference of one eluting balloon over the other? Thank you.
That's a great question. I left out a lot of things. One of them is the paclitaxel and sirolimus, and this is kind of a hot topic now. The one that we have, the Asian ID, is a paclitaxel balloon, and it seems like based on all data, the paclitaxel is still the gold standard, and there are a few studies going on. There's one that I'm involved with that actually kind of shows that paclitaxel is somehow superior, but we still don't know. And the one that we have in the US is paclitaxel, so we don't have a lot of choices to choose from anyway.
Maybe you can borrow Michael's, here we go.
Yeah, so we've had drug-eluting balloons for many years now, and they're very useful. They're very useful for small vessels, which you're not going to be putting stents in. So the distal diffuse LAD, that's poor for bypass in the multivessel patient, where you don't want to put a long 2 millimeter diameter balloon. That's not going to go well. But in ISR, use them a lot, but you need to do more, and I'm not sure that a cutting balloon is enough in severe diffuse. You have to ablate. And once you ablate, then I think the DCB can be very effective, especially in resistant. I don't know if you have to wait for the second layer of stent. If you have diffuse ISR with one stent layer, first make sure that the stent was deployed appropriately, and that's we always need to image to make sure that the stent was in fact the right size for the vessel, and then ablate, and then use a drug-eluting balloon, and I think that's very effective. Paclitaxel is what we've used for many years. I think that's where most of the data is.
Okay, great. Well, thank you very much, Michael. Terrific talk. We're going to move on, and now my co-moderator, Tim Henry, is going to talk about the future of shock management. Severe angina, and which is unable to be revascularized.
So Manas, really another great session. Where is Manas now? Did we miss him? But anyway, it's been a really great meeting again, and I'm going to talk a little bit about severe angina and patients that you can't revascularize. So we'll start with the patient, but then this is a lot of patients, and we'll come back. This is a 70-year-old who had class 3 angina, 2 MIs, 76 and 82, had a bypass in 91, a redo in 2009, and he continued to have progression of disease, had a pacemaker, bradycardia. 2017, EF was 30%, and he had abnormal coronary flow reserve, as well as ischemia in the LAD, and an occlusion of the jump to the right. So lots of ischemia. So this is a common patient. So the important part of this is this patient's now had coronary disease for 50 years. So one of the things that's happened is we've made a big difference, and we're actually keeping people alive. This patient was put in a coronary sinus reducer trial and had a significant reduction, and we're going to talk a little bit about the options for these. So first of all, this is becoming more common. And there's estimated now 10 to 12 million people in the United States have chronic angina, although we really don't know. And it's probably more closer to 16 to 20 million. We do know this, about 10 to 15% of people that have a cardiac catheterization have ischemia that's not ideal for revascularization. And you know chronic total occlusions, degenerated vein grafts, bad comorbidities. To give you an example, in the COURAGE trial, at 1 year, 42% of the medical therapy arm still had angina, and 34% of the PCI arm still had angina. And second, if you look at ischemia, they did it the opposite way. The number of people that are angina-free at 1 year was 60% in the PCI. That means 40% still had angina, and 25% in the medical therapy arm, which means 75% still had angina. So there's a lot of angina out there, and we're not doing a great job of treating it. Why do people have chest pain? And I think this is really where this is changing now. It's not just epicardial disease, and that's going to be a focus one here. So you have epicardial disease, you have microvascular disease, and you have vasoconstriction. And patients don't put themselves in buckets. Most patients, many patients at least, have more than one of these. And you have to think about that as you go forward. Another issue about this is, why do people have chest pain? Is this heart-brain connection? And how do people perceive chest pain? So that's why this becomes such a very complicated area. Another really key point in the beginning is, first of all, there's no great places to look at registries. We had the largest registry when I was at the Minneapolis Heart Institute. We have almost over 2,000 patients in it. And we think of this as a high morbidity mortality thing. It's not anymore, because we have really good secondary prevention. And so what we did is we looked at patients who had refractory angina, not amenable to revascularization, and we looked at them over time. The mortality per year was only about 2.5%. That's not much difference than age-matched controls. So one of the things is we've changed this from a mortality disease to a quality of life disease, and I think that's an important point. So who are these patients? And another thing that I think is, and we've been doing this now for about 10 or 15 years, trying to shift the way we think, and now we have a paper in European Heart Journal that's going to officially make this change. But when people think of refractory angina, they think that they have a severe obstructive coronary disease. That's not really true. So if you look at these, we published this with Mark Jolliker a few years ago. There's really 4 categories. Phenotype A is actually microvascular disease. So they have severe angina despite medication, and they're not amenable for revascularization. That's refractory angina. If you look at phenotype B, that's the classic CTO patient. And we've done a good job with them, and we're going to talk about that in a minute. If you look at phenotype C, this is a type 1 or type 2 diabetic that has diffuse distal and side branch disease. And then phenotype D is like the patient I presented, 2 bypasses, 15 PCIs, and really just advanced coronary disease, but still alive with well-preserved ejection fraction. So what did we do? We have had a clinic for a long time, and I'll talk about that in a minute. But what you do is you do optimal medical management, risk factor modification, stop smoking, LDL less than 55, and then have multiple options for those patients. And you can, if you have a clinic that looks at these patients, you can actually make a difference in, we know that we've published 85% of the patients have improvement in their angina by 1 year. But you need to have multiple options. So what are those? So before I go to the what I think are some key options that we'll talk about briefly is, another point, these might be a no-option patient now, but if you look at all the trials over the course of 2 years, 25% of those patients have a subsequent revascularization. And why? We looked at that, and it turns out 48% of people had new lesions, 21% of patients had restenosis, and then 30% of the time, patients, you were forced into doing something that maybe you didn't really want to do. But that progression of disease, a lot of it was old vein grafts. So you need to look at the old angiogram and say, is there a place that this could be getting worse, and decide if a patient needs a subsequent angiogram or not. So let's just shift and talk about a key things from an interventionist standpoint. So don't forget that CTO PCI is an incredibly important part of this. And so in our angina clinic, we have a really good relationship with my CTO specialist, which is Jared Frizzell, and it's made a big difference for a lot of patients. So we get a ton of referrals. I see about 20 to 25 patients in clinic every week, and usually 15 plus of them are refractory angina. But Jared and I always look at it and say, what can we fix and what can't we fix? So that's a really important part of having a refractory angina clinic. Another one is cell therapy, regenerative therapy. People have forgotten about this, but I want to point out, this is a CD34 cells that we actually published in European Heart Journal. Significant improvement in angina, significant improvement in exercise time, and actually improvement in mortality. Why aren't we using it? Because it's the business plan. It was too expensive. So what is happening? So this is brand new data that was just published in Circulation. This is actually with the gene that encodes for multiple isoforms of VEGF. excellent results in this phase 1 study, and if you looked at it, 93% of the patients had improvement in, if you look at angina, PET scan, and exercise time, 93% of the patients had improvement in 2 out of 3. So there's a new randomized trial, double-blind trial, that will go with intramyocardial injection of the gene for VEGF that will start this year. There also is a stem cell trial still ongoing where you actually, in the cath lab, do a bone marrow, pick out patients who have good high CD34 cells, and then inject them right there. So the regenerative therapy has not gone away, and I actually personally think the vectors are better, and the gene products are better, and it's cheaper. So now I'm going to shift and talk about coronary sinus reducer. So this is, I think, a really important. It's approved in Europe. This is actually a follow-up of the Beck trial where you actually occluded the coronary sinus, tied off it. That might have been a procedure if we hadn't developed bypass surgery. But instead now we've actually got a hourglass-shaped stent that goes in the coronary sinus and changes the endocardial to epicardial blood flow, and I'll show you this. This is what it does. It's 9 French, you go IJ, very simple procedure. I actually do them last 7 or 8. I've just done by myself, 1 operator, takes less than 30 minutes. You put this stent in the coronary sinus, and it changes the outflow. And the way that it works is this changing of the endocardial to epicardial ratio. And it also shows that there's a significant improvement in coronary flow reserve. So this is the data from the COSIRA 1 published in New England Journal. Randomized 100 patients to reduce or sham control, showed a significant improvement in angina, and that's led now to the COSIRA 2 trial. But this led to improvement in Europe, and more than 4,000 patients have gotten the reducer worldwide. This is what it is. It stays patent long term, so really there's data out to 15 years that shows it stays patent, but you have an outflow track gradient across the thing. Data at the ACC just showed, this is the Orbita Cosmic trial, that actually showed reducer versus placebo, showed a significant reduction in angina. This is an anti-anginal agent. So I would encourage you, this is the data, and there's multiple trials now that show improvement in coronary flow reserve. So I think a lot of these patients with advanced coronary disease, the reason they have chest pain is not just the epicardial disease, because they have abnormal microvascular disease. And the reducer improves microvascular function. So this is the trial running now. We need people to enroll, and we need sites. They're going to be up to 380 patients, ideally, hopefully less than 400 at 50 sites in US and Canada, randomized to reducer versus sham control. We have about 75 to 80 patients randomized already. We also have registries for microvascular disease, for right coronary disease, and for patients who can't walk on the treadmill. Right now, the primary endpoint is exercise time, but based on Orbita Cosmic, we might change that. The last I'm going to end with is don't forget microvascular disease. Patients who have microvascular disease have an increased incidence of MACE. This is a common problem that you come to the cath lab with chest pain and have no obstructive coronary disease. And this is a show, if you have abnormal coronary flow reserve, you have a significant increase in MACE. We've shown that by diagnosing microvascular disease, you can improve outcomes. Big surprise, if you know what you're treating, you can treat it better. But where it's still under-recognized and undertreated in the United States, this is the data, again, that shows a decrease in your IMR, increase in your CFR, improvement in chest pain. So, and there are ways to treat it. This is cell therapy data, there's coronary sinus reducer data, and there's a lot of things coming. So I'm going to end with this. Your patient has chest pain, don't just focus on the epicardial disease. You have epicardial disease, you have vasoconstrictive disease, and you have microvascular disease, and most patients have a combination of those. To do this well, you need a dedicated angina clinic. And I can just tell you, we started it when I went to Cincinnati. We're overwhelmed. 3 months wait for a women's heart program, 3 months wait to get a CTO, 3 months wait to get to my clinic almost. So there's 3 of us that work together, and we call it, you don't want to send your mom 4 hours to go to the no option clinic. So we call it our care program, and it's been incredibly successful. So if anybody that's out there is interested, we're happy to help. Thanks.
Excellent branding, Tim. No, thanks. That was a terrific talk. And open it up for questions in the panel. I'll start off by just asking you some specific and then kind of a general follow-up question. The specific is for COSIRA study, like how, as you mentioned, it can be a very heterogeneous population. And so which group are you focusing on? Is it pure microvascular dysfunction? Is it vasospasm? And then also maybe you can just discuss how you evaluate those patients in the cath lab, what you do, your technique.
So first of all, for the trial, we're looking at obstructive coronary disease. So you have to have class 3 or 4 angina, non-amenable to revascularization, and we have a group of people that review every case with you, and not easily review. So like, this eye of the beholder is when you can revascularize. But I will tell you, a lot of our highest enrollers are CTO specialists, because they know that opening that CTO for the 3rd time is not going to really help. And then patients are randomized to the reducer versus placebo or sham procedure, but you can cross over at 1 year. So I think it's a really important trial because we need more options in the United States. The only thing approved for refractory angina in the United States is EECP and TMR. And then Renolazine probably works as well. In terms of the microvascular disease, we can't do everybody, but if someone has class 3 angina despite medical therapy and no obstructive disease, then we're doing invasive microvascular testing, including acetylcholine for spasm and currently thermodilution for coronary flow reserve and IMR.
Yeah, I had a question. I just want to take a step back about it and think about it, maybe poll the audience. So mostly interventional cardiologists here, you mentioned data that 30–40% of patients may continue to have angina, but oftentimes the question is, how big is the problem really? So a show of hands in the audience, you guys are all doing stenting. What percent of your patients still have recurrent angina? Is it more than 30%? Is it less than 10%? You think 20%? Yeah, I'm not sure. I mean, I think it's less than that. So the question I have is, under absolutely amazing medical therapy, what percent of the patients really continue to have recurrent angina, and what is your process for optimizing them before these other therapies?
Yeah, so obviously there's a spectrum between a little bit of angina and class 3 angina, so that's one important thing. But multiple trials all show consistent if you ask people. We don't always ask people, and we don't ask, my big question is, how far can you walk? And you're frequently surprised how limited, and why? And then you find out they actually have more symptoms than you think. So I think we don't appreciate it as well. And a lot of patients, how many times they come to the cath lab? Chest pain, abdominal stress test. Oops, there's nothing I can fix. So you futz with the beta blocker, you increase the nitrates, and then you don't see them back. But when you have a dedicated, trust me, we open this up, floodgates.
I just have a question. Obviously, you're looking at the coronary sinus reducer right now in refractory angina patients. Do you think there may be speculatively any role for this down the line in an earlier scenario for patients, say medication intolerances, or would it help with angina management on a broader scale at any point?
Allison, that's a terrific question. So first of all, these people are living for a long time. And if you look at regenerative therapy or EECP or the coronary sinus reducer or medications or CTO, they're not competitive. Most of these patients have had more than one. So you need to think about that as a holistic way of how can I decrease their symptoms. So I think if it was approved, we would use it more often. And I think EECP is another thing that's underutilized out there. It's just logistically not available to too many patients.
Great. Well, thank you, Tim. That was terrific. We'll move on to our last talk, and this is The Future of Shock Management by Srihari Naidu.
All right. Hey, buddy. Good to see you. Oh, okay. I don't really need this because I'm going to do one slide.
It's like a low contrast PCI.
Yeah, exactly. So I'm going to try to take you through my mentality about where shock is going. Obviously, I've been involved in the field. Tim and others have been involved in the field for a long time. So I'm going to take a little bit more of an overview. So this is my sort of 5-point plan on where we're going with shock management that I think we should all think about. I'll start on the top left here. The first thing we're going to do is update the guideline or the consensus document. I think the field is moving very rapidly. And I'm very thankful for that. It's really amazing to see that there's so many people interested in shock. We have whole heart failure sessions here now. And the field is moving fast. When the field moves fast, the education lags behind, right? So the knowledge base lags behind. We start coming out with guidelines, statements on how to do this. We have to teach people. Innovation moves forward. We have more tools. We don't know how to use these tools. And then we do the trials that show that maybe the tools aren't working well, and we try to fine tune. So first thing we're going to do is put together another consensus document and update this Sky Shock stages. Why? Because each iteration we've learned more, and it's rapidly evolving. So now we have to figure out the different etiologies of shock. How do they incorporate? Do we need different pyramids for these things? Because each of the etiologies at different shock stages have a different prognosis, and they also have a different type of armamentarium of tools that we have to get involved in. So number one, we're going to do that to talk about the etiologies, the phenotypes. We need to further fine-tune these stages based on etiology and phenotype. Also the time course of shock. We've figured out now that it's not just enough to figure out what the Sky Shock stage is at baseline. We have to figure out what is the time course, what happens in the first few hours, what happens in the first day, how do you redefine shock at that point, what is the most likely area that we have to impact. It turns out it's probably within the first day, but that has to be updated as well. That puts a lot of incentive to do devices and therapies that maximize volume, congestion, output, hemodynamics, all within the first day to try to improve the survival. Because we've also learned that the higher the shock stage you go, even in the hospitalization, even if you get them all to discharge and alive, the ones who have the highest shock stages end up dying more at the year. So we need to be much more aggressive early on. So that's what shock is doing right now. We will still at the same time want to maintain simplicity, because one of the best things of the Sky Shock stages was that it could be applied everywhere, in EMS, in the ER, critical care, cath lab, everywhere. So you want to maintain that simplicity, and that's going to be a big challenge in shock, how to keep updating the guidelines and the stages, add more complexity. As you learn more complexity, maintaining it very simple. So that's one thing Sky is going to do over the next 1 to 2 years. Myself and Naveen Kapoor will probably lead this next round. On the bottom left, I'm going to talk about protocol versus device management. We spent a lot of time on device management. Now we've realized that the protocols matter much more. And why do protocols matter? Protocols matter because it's more of a thought process on how to treat patients, and protocols can change over time. Devices make the assumption that you put one device in, it's going to cure everything. We've done that for many years, and it didn't really work. The first one that kind of did that was danger shock that just came out, but it still did it in the form of a protocol to try to minimize drips and things like that. So we need to figure out the protocols that work. The other reason why protocols are important is because every hospital in every part of the world has different protocols because they have different resources, different people, different resources, different cost structure, different availability. And because of that, you have to figure out what works in your institution. So that's going to be very important. If you look at the different devices, I think I'm going to separate this out. In terms of the LV, we need devices that are powerful, that match the demand that the body needs, but also have minimal complications. We learned from danger shock that there was an absolute 13% reduction in mortality. That's a huge reduction in mortality. But these patients had a much higher risk of renal failure, much more ischemic complications, much more bleeding. So we need to evolve in terms of bleeding avoidance strategies, ischemic avoiding strategies, smaller catheters, better anticoagulation strategies that minimize this, because we all know that the more complications you have, that also increases the mortality. And the fact that they have an absolute reduction means that all of those didn't accrue to enough mortality to offset it, but it does mean that you would have probably a much higher benefit if you didn't have that ischemic and bleeding complications. So the field has to evolve towards bleeding and ischemic complications, just like we did in PCI with radial interventions and other things like that. In terms of the LV also, I think there's some room to go in terms of minimizing infarct size. We know the supersaturated oxygen, we think we'll do this. We know now that, or we're trying out to see if DTU will work. Can we put devices in to decrease infarct size? We know that infarct size portends a higher amount of shock, right? Especially in the anterior wall. So can we do things preemptively to decrease infarct size? And that also ties in to pre-hospital, which I'll talk about a little bit, and Tim's done a lot of work on this as well. How do we get patients earlier? Most of the shock happens because they're late presenting, or they're mechanical complications, but typically late presenting MIs. That means it's not as much that we can do as much as what could have been done beforehand. So we have to start moving more towards pre-hospital education and community awareness and EMS systems that bring these patients to us earlier. In terms of the RV, now we have devices in the RV. We've always had them, but now we have ones that are easier to put in. The Impella Flex, RP Flex now can be put in from the neck. It's a very easy procedure now. We've done some at our institution as well. But what we've learned, though, in a busy transplant center is we don't know exactly when to put this in. We put it in, we're trying to match to the LV, it's not exactly clear, and then all of a sudden you still have to go to ECMO or whatnot, and you can't tell. So we need to fine-tune who needs RV infarction or RV support, or who can just be better optimized with the LV support, so this knowledge base has to grow. Again, we have devices and not sure where to use them. Let's move on to congestion profiles. We need to know we've learned now that the congestion profile is very, very important. It's really part of this cardiorenal syndrome, and really if you can get rid of congestion earlier, that would make a big difference. So now we have devices to manage preload in investigation, but I think more importantly, we may have to figure out how do we manage fluid quicker than just diuretics? Are there ways to get fluid off easier? Are there ways to ultrafiltrate that are easier hemodynamically for patients and can be done in the first 24 hours to minimize the congestion profile, improve renal perfusion, and allow diuretics to work more aggressively. So this is one way we have to go as well. And finally, we've done nothing for SIRS. We've done nothing for the inflammatory response system. We have nothing for that. Hypothermia kind of went away, came and went away, but we don't have much for inflammatory syndromes, and really that whole field has to evolve. We have no idea how to handle these patients at stage E in that situation. The other boxes are a little bit easier to discuss. We need to figure out team-based shock management. And really, how does virtual shock teams work here? So is there a potential? We have a system where we have smaller hospitals, middle-sized hospitals, and our mothership. We do not talk to them in the process as they're taking care of these patients. So they call us when they need us, when they think they need us, but they don't call us ahead of time. So it would be better if we had apps or virtual systems where we can monitor these patients that are put into there, where we can see what's coming in the community, what's happening out there. And somebody like the EICUs can monitor these patients and try to figure out who needs to be earlier transferred, who we can help them assist over there based on their local resources, and who really needs to be transferred right away. So these are areas that we have to evolve as a community, and I think Sky will also help working in that direction as well. Transfer triggers, system-based care. On the bottom two ones, I think this is more global types of issues here. We need more intersocietal, interdisciplinary collaboration. I think that's part of something I'm going to work on very heavily during my term at Sky, which is how to work with all the different organizations to tackle diseases in a more comprehensive way. That means the heart failure people, the critical care people, and that's why we have Sky Shock, the course, and that's why we separated the course out so that we can have all of these people look at it as we're all charged of shock, not just Sky, but all of us come to the table to try to figure this out. We need more randomized trials. I think they stopped RECOVER, which I understand why they stopped RECOVER, but I think that we need more trials in this space to show what's working. We got to work with all the different areas in this. One of the challenges we have in shock, in my opinion, is as it's gotten bigger, more people interested. When more people are interested, they start doing their own little things. So we have the working group, we have Sky, we have heart failure, we have critical care, we have everybody now involved in shock. How do we make sure that something that we kind of centralized doesn't get decentralized too much so that we can still move that whole shift forward? So that's a big area that shock has to move in. And I think that's why, at least for me personally, I've been making sure that I'm keeping all these connections going. And if we do a new document, I get Naveen in and get other people in, so we keep everybody thinking the same way, because ultimately what we don't want is a fragmented way of tackling a disease. Now the last thing is, in this country we're very advanced, but we're very not advanced in the majority of the country. So there was a study that came out that has nothing to do with shock, but half of the counties in the United States have no cardiologists. That's an eye-opener. Why is it an eye-opener? It tells you that half of America is pretty much rural, okay? So we have in this country the same problems that we think we have in other countries that don't have as much economic means. And so we don't have a good way of taking care of all of our patients at all. We think that we're doing a good job because our major hospitals do a good job, but then most patients are not getting good care, or half of America is not getting good care. So how do we change that? That means that we have to talk to government agencies and figure out how to do tiers of systems for shock. We need to figure out also how to get the best shock care to the local environments, to the best of their abilities, and have efficient transfer protocols just like STEMI care and stroke care for shock as well. So shock is sort of the next area after STEMI care and after after stroke care, I think shock is becoming the big one. So I do think that the final thing is that we need international shock management, meaning that we need to do things in the communities and other places where they don't have all this technology, where a lot of it is patients not coming to the hospital or not coming in and dying in the field. And unfortunately, things that happen outside the hospital, we don't take any responsibility for. But we should, because if we're a healthcare system and a healthcare workforce, these are all people that we're supposed to get to the system, and I think we have not done a good job there. We need technologies that are cheaper and more transportable so that we can help these patients come to the hospital so that they're in better shape by the time they get here. And it's possible that novel pharmaceuticals can work in this way as well. Are there things that you can give patients at the time of large STEMIs that might protect them in different ways as they come to the table? So I'm going to end there with my one slide that I think has a lot of thought-provoking. I didn't dive too much into a lot of the details, but try to give you a little bit of an idea about, I think, where the field should go over the next 5 to 10 years. Thank you very much.
Terrific. I love it. Very concise with the one slide. So yeah, maybe we can spend some time talking a little bit about some of the current controversies. And you mentioned mechanical circulatory support and danger shock, and based on the positive findings, how Recover 4 was stopped. Interested in hearing your feelings about the implementation of mechanical circulatory support. Which technique, and do you think the study should have been stopped?
Yeah, I think, so I believe the data. So I do think that danger shock showed that Impella does work, and I do believe that in that population, the absolute reduction in mortality was impressive, and it overshadowed the increase in mortality from the complications. The question is, are we okay with that equation? And I think some people are not. So I think we as a community are perfectly fine with saying we're happy with a mortality improvement. Patients and other people may or may not. And I think so that's the one question. So I think even though it's a slam dunk for some people, for other people, it'll be like, well, those complications are major complications, and it's a lot of work for us, right? So I mean, I'm being honest. So in the hospital, they'll be like, well, that's a lot of things to worry about with that device, right? And we're all driven by negative feedback as well as positive feedback. So that's the first thing. The second thing, and we've had this debate in our hospital, is that I think a lot of hospitals, they use Impella, but they also use balloon pump. And they use balloon pump, and they transition rapidly to ECMO in patients who don't benefit. And I think there's a philosophy that maybe you minimize the complications because you go from a percutaneous that has a low profile to surgical types of things that they can monitor and aggressively watch and make sure there's no complications because it's visualized in person. And if you do that rapidly with the first 24 hours, maybe that's just as good as Impella for a few days. We don't know. So when this whole thing came up, I did talk to Greg and others about continuing the trial because I felt that we really needed two things. One is you need a confirmatory trial. And number two, I think you need a confirmatory trial in a country where they're still using a lot of balloon pumps because it's not a class 3, to show that the algorithm of balloon pump to ECMO, or balloon pump to rapidly ECMO, Impella perhaps, is not going to be as good as just doing Impella and sitting for a few days and then maybe avoiding some ECMO in those patients. And we needed that. And so I wish that they had continued it because I think it's going to move the needle a little bit too slowly right now. People who are believers will continue to believe, and people who are not sure have a little bit of an out right now. I don't know. I want to hear what Tim and others and Mauricio.
So really good, and it covers a lot. This is such an important topic, and we've made very little headway. I'm going to just say two things. First, I think for us to make progress, we need shock centers using standardized protocol in sites that will enroll people in clinical trials and keep track of their data. And I think really similar to STEMI. And maybe one of the problems we have is, we might have too many STEMI systems, and so this all gets, you don't have centers that it's concentrated. In the areas of the country that have done a better job with shock have organized shock system. But I want to ask Vlad. So Vlad, you were a key investigator in the shock trial, which changed all this a really long time ago. What have we done wrong since then?
Well, obviously, revascularization, that was the right thing. And we had done the balloon pump. I think there's a lot of bias and a lot of lack of equipoise about the different support devices, specifically Impella. I mean, you talk about Recover 4 being stopped. Recover 1 enrolled one patient, right? That was before the high-risk PCI trial that actually was stopped early, also should have been stopped early. But yeah, Recover 4, I agree with you that Recover 4 should have continued based on the lessons from Danger Shock, where vascular complications were markedly increased. And how can you do that? How can you improve that? So I think a lot of people jumping into a device, I think that's probably been a bit of a problem. Balloon pump, lots of people use balloon pump. Lots of countries, lots of places can't afford the really expensive devices. So balloon pump still works. There's some data. There's a little bit of data that if you do it early, just like there was data with Impella, that you actually improved outcome. And some data that if you do it before reperfusion, shock IBP, actually in 84% of the patients, they deployed the balloon pump after reperfusion, which I think is a big problem. So those are some of the things. The whole issue of reperfusion injury, which we've tackled in the past, which I think is still a big problem when you reperfuse these patients. You know, you get VT, you get further depression of myocardial function, you need to upsize your pressor requirements. So I think those are some of the things we still need to deal with. Danger shock is a big step, but I agree with you fully. It needed confirmatory data, and we still need to explore some of these other older technologies in a newer way, because I think many patients actually benefit from balloon pump alone if you deploy it early, for example. Okay, so these are some of the things. I hope that's...
Comment.
Can I ask I'm going to turn it to you, Chadi, in a second. Can we ask a question? How many in here, a series of questions, and answer it honestly, how many have a specified shock team at your hospital? So small. How many have a standardized algorithm, standardized protocol that you use? And how many keep track of your data and review your data monthly or quarterly? So that's good. There's some, but you can see it should be every one of us raise our hands. And I think we'd do better if we did that. So I'm sorry, Chadi.
No problem. I just want to make a comment to Harriet to speak about heterogeneity when the Impella. So our center, we were Impella heavy for shock, and then after COVID became ECMO heavy for shock. So we looked at the data to see what is the difference. It's just culture. Surgeon came over, they said, we're running the shock, we're doing ECMOs, done. I mean, there's no science, nothing, just this culture change. But what we notice is the outcome, after we control for bleed, ischemic limbs and stuff, the only variable that predicts good outcome is early recognition.
Early recognition.
Recognition.
Yeah.
If you know the shock is going to happen and you implement, regardless what you have in your toolbox, Impella, ECMO, whatever you have, patient will do well. I think that's the key thing. That's the only variable was associated with good outcome. And then, as I said, after controlling with other things. But that speaks to your algorithm or your chart, saying if you know it, if you have a system, who to call, who to activate, and get it done, patient will do well.
That's why we're proud of the Sky Shock stages, because I think people didn't check, and what we were calling stage C was really mostly stage D. People already crashing, and they weren't identifying them before they crashed.
Yeah, excellent presentation. And I like what you said about protocol-based versus device-based therapies, because as you said, our institutions are all different as to what we have on the shelf. And I think Dr. Tamis-Holland also alluded to that in her talk as well. You know, fibrinolytics are not going to go away because there are lots of places that don't have PCI capability. If you go to North Dakota, and you mentioned that as well, the recent paper, a lot of places in the US don't have a cardiologist. And so I think it's also important for us to recognize that the business of medicine is just as important as what we do. And we all have to get involved in advocacy, like you mentioned, in our societies, SCI, ACC, to ensure that as we get the science, that we're also able to implement the science in the US and other countries.
All right, Bill had to go to the airport, and we're right at time, but I want to go on this side and go Allison in this way and just make final comments. Allison, you have a shock team, so let's hear how it works.
Actually, that's somewhat incorrect. I don't have a very formalized shock team at my center. We do have more of an ECMO team, if that makes sense. So I'm in Canada, I should clarify that. So one of the things I've been trying to work on actually is, as was already mentioned, it's so important that upstream care, prior to even getting to the point of deciding, you know, am I putting an Impella, am I using a balloon pump or ECMO, to have an excellent streamlined approach to initial recognition and guidelines-based management of shock patients before you even reach that decision point. So that's something that I'm working on a bit at my own institution. Interestingly enough, you know, like as was said, the dangerous shock data was not enough to really change practice patterns at my center in terms of generating a lot of enthusiasm for getting Impella, unfortunately, in Canadian climate. So I think the best thing we can do now is just to work on that upstream care and wait till we get more convincing data in a system like I operate in. Of course, across Canada, there's a wide practice pattern variation in other centers that have everything available. But in terms of how our ECMO team does operate, essentially, once we start to recognize that we need additional support for these patients, we call all the appropriate individuals, and it's a multidisciplinary team involving cardiologists, cardiac surgeons, some of our individuals that have a bit more focus in heart failure management, ICU, CVI-ICU. So, and we look at each case in terms of appropriateness. And that's a big thing for us, is deciding whether this person really has a potential to benefit because of our resource constraints with perfusion and resource use when we put someone on a circuit. So there's so many different factors. You know, when you think about shock care, you really have to think about it on a broader level, and, you know, not every institution has everything available and the resources to do everything that we'd like to do, so.
Dr. Henry, may I actually pivot and go back and make one comment about the DCB topic? As a peripheral interventionalist, I think Dr. Berlakis made a mistake and put me in the wrong section, but then I heard DCB and my ears perked up. And I say that mostly because DCB has been very evolutionary in the peripheral space. Obviously, we use it for ISR, but particularly in the femoral popliteal regions, we're using it in native vessels, and we're not leaving anything behind in those patients. And keeping in the theme with, you know, the future of PCI and beyond, will we ever see in our lifetime DCB not only used for ISR, but maybe even native vessels, large epicardial native vessels in the coronary space, understanding that the pathophys isn't quite the same in the peripheral or the coronary, but addressing Dr. Jacqueline's talk, will it be used in STEMI, right? Focus on the DCB of the culprit lesion and then really focus on reperfusion injury, or in Michael's talk about vulnerable plaque, or excuse me, Salman's talk about vulnerable plaque. Instead of putting a stent on a vulnerable plaque, could we use a DCB? So I think the foundation of our field is excellent, and I think it's a great time to be in our field to see where all of these technologies go.
Perfect, thank you. So great lecture, Hari. I think it showed very well integrated all the aspects of shock care. So my comment is to emphasize the care in the cath lab. So don't take shortcuts. Get the vessel reperfused, stabilize the patient first, and never forget to assess the hemodynamics. You need to understand the hemodynamics, because with that you can predict what's going to happen. And then the integration with the heart failure team and the critical care team is crucial for this. So I don't want to take too long. I think many of us have to go to the airport. So thank you. It's been a great pleasure to be here.
Yeah, so thanks everyone. Manos, thanks for really a great meeting, and I hope everyone gets to the airport and gets home. And the last comment, I completely agree with you about DCB. Around the world, it's transformed it. I was just at an international STEMI conference in the last 6 months, and probably half of the STEMIs are being treated with DCBs in many parts of the world. So for us, we're way behind the treatment. So, all right, thanks everybody.
Thanks again, and we have the final competition. So.